making sense. Can't see it. All right. So last time we discussed the role of race in health treatments and outcomes. We looked a little bit at the causal role of race, if any, race and ethnicity, if any, in different sorts of health outcomes. And we examined ways of distinguishing different kinds of disparities. When we see disparities in health outcomes, what do we make of them, what might be their causes? Introduced a number of more subtle ways of understanding the origins and meaning difference across different kinds of groups in our society. We looked a little bit at the role of ethnically patterned patient preferences, a little bit at the role of physician decision-making and of geography in race and ethnicity-based differences in health and health outcomes, and we introduced the notion of the difference between bias, stereotyping, and uncertainty. Now today I want to sort of switch gears a little bit and talk about this book and some of the ideas in the book, Emily Martin's The Woman in the Body. When I first read this book in medical school like 30 years ago, it had an extraordinary impact on me. And we're going to be speaking a little bit about not just the intellectual content of that book, but more broadly the ideas that are captured in this volume. So let's refresh our memory a little bit about different ways of defining health or defining medical conditions. Remember, we introduced the notion of a statistical definition, which compares people to their peers, an adaptive definition, which compares people to their environment, and this notion of a social definition, which compares people to normative ideas about what is or is not a disease or a condition or an illness. And note that the normative standard is not the same as the normality statistical standard. Another way to understand this is to say that the social standard is when we speak of the social standard for the definition of an illness or a disease, we're talking about how illness and disease are socially constructed. And the social construction of illness is the opposite of essentialism and of positivism, which sees social and biological phenomena as given and measurable entities with a fundamental essence, and which claim that the truth is knowable via the scientific method. So on the one hand, we have a set of ideas that said there's an objective reality out there, illness and disease exist outside of us, we can go and we can use the scientific method to understand it. And there's another set of ideas that say, no, this objective reality is subjectively created by human beings, that we cannot actually ever fully appreciate the objective nature of reality. And the argument with respect to social construction is that observations are actively and creatively produced by human beings. Knowledge, in other words, is created, not found. And ideas and actions are made or invented and determined by communal norms and expectations. Hence, the social factors that shape our understanding about and our actions towards illness and health are also similarly affected. And to the extent that this is the case, then social attributes, such as class, for example, should also be relevant to how ostensibly objective biological phenomena are seen, taxonomized, understood, and treated. And moreover, the fact that illness and our perceptions of bodily processes are socially constructed has implications for patient experience and physician outcome. And this is a key idea I'm going to communicate today. It's not just sort of some fuzzy thinking or, oh, illness is socially constructed, isn't that interesting, and we'll come to this. It's that if that's the case, and it is, then it means that we act on that. It's the fact that we act on how we observe the world that's especially important in the healthcare setting. Now, to punch this point home and to motivate our discussion for today, I thought I would start by considering a related problem. And here is the familiar visual part of the electromagnetic spectrum that you all studied in high school physics or chemistry that we know as light, with the familiar rainbow colors. And the colors are listed at the bottom, and with a possible exception, and I want to draw attention to two facts for you looking at this electromagnetic spectrum. The first is that you probably all feel, with a possible exception of indigo, that all these color names make sense, and that these are real colors. And moreover, that there are a certain number of colors. There's red, orange, yellow, green, blue, skip indigo, and violet, purple, okay? So those are like the colors of the spectrum, and these names make sense. And second, and distinctly, you would probably all agree on roughly where the names should be placed. So that you all see green as, ending roughly here, and then blue begins. None of you are going to say the green ends over here, for example, or begins over there, for example. So the color names are what you would all expect, and the boundaries between the colors are things that you would, mostly speaking, tend to agree on. But actually, of course, as you can imagine perhaps where I'm headed, there's very little that is objective about both of those, both about the number of colors we perceive and the boundaries that we draw between them. For example, the number of colors we identify might depend on other attributes, like our sex, for example. One group of people might see many colors and another group of people might see few colors. But let's look at some more serious experiments using large-scale, worldwide data sets. On the top here is a set of stimuli used in something known as the World Color Survey. It's a palette of 330 colors, and they're on separate little squares. And what's done is you go around the world, and you show one square at a time to a respondent, and you ask them, what color is this? What do you call this color? And then you show them another square, and another square, and another square. And you do that for many respondents in each of many groups around the world. Now what the investigators then did is they recorded the color term that was assigned to each of these 330 chips by the largest number of speakers in each language. So they measured the modal response. Like for this chip, most people called it red. Or for this chip, most people called it yellow. And then they marked that word that was used by the people in that culture on the relevant spot in this grid that's, whatever it is, 33 by 10. And so they made a mode map, such as shown in the lower panel, which is the mode map for the Lili, a language with 4 major categories. And each category is denoted by a color. And amongst the Lili people, they have just 4 different colors. Red, black, yellow, and white. And I forgot what the blue is. I think there's not enough data or something. They just have 4 colors, these people. Not like we have 7 colors. And furthermore, this is where they draw the boundaries. Like this is red, and this is red, and all of this is what they call yellow. They don't have different words for all of those colors. And they have these colors here are all black colors. And these on the top, regardless of the shading, are all called white in their language. So interestingly, there were clear universals and also clear differences in color naming across societies as these investigators studied, such that both the number of recognized colors and the boundaries of the colors varied from place to place. So the recognition of colors is in part socially constructed and transcends the physics of the situation. Which colors you see and how many colors you have is not about the objective reality of the electromagnetic spectrum. It's socially constructed by how you were raised. We don't think the eyes of the Lili people work different than our eyes. We think they have been in culture to draw the boundaries this way and to only have 4 colors. But there's a further key idea that I want to explore today, is that once constructed, such categories can then have effects. The controversial Whorf hypothesis that was propounded in the 1950s and explored in the sci-fi film The Arrival. Did anyone see Arrival? Oh my god, it's a great movie. Anyway, it's explored in this movie, the Sapir-Whorf hypothesis, holds that semantic differences between language induce differences in perception and cognition. And this idea has a checkered history, but it has been resurrected of late. And so the question would be, do linguistically coded color categories induce actual differences in color discrimination? If you grow up in a country or in a culture in which there are only 4 color names and these are the boundaries, does it make it more difficult for you to see the difference between other colors that might be within those categories? So for example, here is an example of people who identify only 3 colors and where they draw the boundaries. So these are the Ejagan people of Nigeria, the Bete people of Ivory Coast, the Wobe people of Ivory Coast, and they only have black, white, and red are the color names, and this is where they draw their boundaries between them. There's some similarity, but also some difference across the group. This is a mode map of peoples around the world to identify 5 colors, and where they draw their boundaries. And in fact, here are some examples of the people who identify 6 colors, and where they draw their boundaries. And this blue-green distinction is key. So for example, a highly variable boundary across cultures is the boundary that's drawn between blue and green. So for example, it's drawn here, it's to the right here, it's sort of shifted over to the left there. There's differences cross-culturally where this boundary is made. Now to be clear, the issue here is also whether people even see these differences. So do you see the difference between shades of green, or do the conventions in your society in which you were raised make you fail to distinguish, or fail even to see the differences between these colors? And it turns out there's evidence for the latter. Your ability to perceive color depends in part on which society you happen to be born in and raised. One study that involved experiments with a gaze of toddlers found that the color discrimination shifted from the right hemisphere to the left hemisphere of the brain once toddlers acquired terms for the relevant color categories. And so language may influence the functional organization of the brain. Maybe initially you're just perceiving the world visually, then we impose a kind of cognitive linguistic order on the mind which shifts which part of the brain is used in order to see these colors. And similar arguments have been made about sounds, such that native speakers of tonal languages, such as Chinese, for example, may natively hear differences that we do not hear. So if you're raised in China, where the tonality of the language is crucial to communication, your whole life, the argument is you learn to hear differently than if you are raised in the United States. And of course, there have always been people, just to be clear, artists and musicians, for example, in any society that may see and hear more than the rest of us. But that's not what I'm talking about today. I'm not talking about individual differences in innate talent for drawing, visual distinctions and subtle colors. We're not, there's Picasso and then there's like me, okay? So he's already different than me. But Picasso and I both partake of like European culture where we have 7 colors, not, let's say in Ecuador where they have 4 colors, for example, in that native population. Or consider the work of Lira Boroditsky regarding the way the Kupthayore talk about space. This group of native indigenous Australians don't actually have words like right and left and forward and back, as we use in English, that define space relative to an observer. In fact, what the Kupthayore do, like many Aboriginal groups, is they use cardinal direction terms, north, south, east, and west, to define space. And then they do this at all scales, which means that they have to say something like, there's an ant on your southeast leg, or move the cup to the north-northwest a little bit, or else you cannot speak properly in their language. And the normal greeting in Kupthayore is, where are you going? And the answer would be something like south-southeast in the middle distance. Okay? So their language doesn't draw space, divide up space the way we divide up space. They use the cardinal directions at every scale, and they do that from the time that they are born. And the result of this is a profound difference in navigational ability and spatial knowledge between speakers of languages that rely primarily on absolute reference frames, like the Kupthayore, and languages that rely on relative reference frames, like English. And speakers of languages like Kupthayore are much better than English speakers at staying oriented and at keeping track of where they are, even in unfamiliar landscapes, or even inside unfamiliar buildings. You can take one of them into an unfamiliar building and walk them around, and they can walk out afterwards, because they have tracked space differently than you or I might track space. And in fact, what enables them, in fact forces them to do this, is their language. Having their attention trained in this way equips them to perform navigational feats that were once thought beyond human capabilities. And as linguist Roman Jacobson pointed out, languages differ essentially in what they must convey, but not in what they may convey. Languages can oblige the users to think in particular ways. And because space is such a fundamental domain of thought, differences in how people think about space don't just end there. People rely on their spatial knowledge to build other, more complex understandings about the world, more abstract representations. For example, how to represent time. And this has also been shown to depend on how we think about space. So the question is, if the Kukthaori think differently about space, do they also think differently about other things, like time? So to test this idea, Boroditsky gave people sets of pictures showing some kind of temporal progression. For example, pictures of a man aging, or a crocodile growing, or a banana being eaten, and gave subjects the job of arranging the shuffled photos on the ground to show their correct temporal order. And she tested each person in 2 separate sittings, each time facing in a different cardinal direction. Now, if you asked English speakers to do this, if I gave you a stack of cards of a banana getting smaller and smaller, and I asked you to arrange it chronologically, what would you do? Left to right. You put this, left to right is what you would do. And if I turned you around and asked you to do it, what would you do? Still left to right, okay? What if you were a native Hebrew speaker? What might you do? Right to left, okay? So something about the language structures how you arrange it in time. What do the Kukthaori do? They do it east to west, no matter what direction they're facing. So they do it this way, this direction, and then so the cards are going away from their body when they're facing one direction and comes towards their body when they're facing another direction. Their language about space structures this abstract idea, how they then think about time, and how they arrange the cards in this way. So they spontaneously use this spatial orientation to construct the representations of time. Their language affected their thinking and also their actions. Now there's one more example I'd like to give of this before we kind of switch to some medical examples. Here's another idea about how language can affect thought and action, because languages indeed differ widely in the ways they encode time and not just space. For example, they differ in whether they require speakers to specify the timing of events, or when timing can just be left unsteady. For example, if you wanted to explain to an English-speaking colleague why you can't attend a meeting later today, you could not say, I go to a seminar. English grammar would oblige you to say, I will go, I am going, I have to go to a seminar, distinguishing the future from the present as you speak. But on the other hand, if you were a speaker of Mandarin, it would be quite natural for you and me to omit the marker of the future and just say, I go listen seminar. Now, this is not to say that Chinese speakers don't know the difference between the future and the past and the present. Of course they do. It's just when they speak, they're not required constantly to pay attention to where they are in chronological time when they're communicating what's happening. In this way, English forces its speakers to habitually divide time between the present and the future in a way that Mandarin, which has no tenses, does not. And as I said, this doesn't mean that Mandarin speakers are unable or less able to understand the difference. They just don't have to. Now, economist Keith Chen tested the hypothesis that languages, like Chinese, that grammatically associate the future and the present, foster future-oriented behavior. So in other words, if you conflate, if your language doesn't make a difference between the future and the present, you think the future is just as important as the present, because your language doesn't force you to draw a difference between the two. And so this idea is that when you think the future is no different than the present, you treat it and your future self with more respect. You don't discount the future as much. And so languages that have a weak future time reference save more money and behave better towards their future selves than vice versa. In other words, if you don't draw a distinction between your future self and your present self, if your language doesn't require you to constantly think about this difference, you think, oh, my future self's important, I better take care of him or her. I better save more money, for example. And this isn't just between English and Chinese speakers. What this investigator did is he looked across a lot of languages, and what he found was that on average, so this is the average total savings rate as a percent of GDP for all of these various countries, and he found that the light bar countries speak weak FDR languages, that is to say, Chinese, for example, and the dark bar countries speak strong FDR languages, what he found was that on average, countries which speak strong FDR languages save 4.75% less. Okay? So if you think your future self is a different person, you don't save as much money. This is another example of the impact of language. You've now seen 3 examples, changing not just how you think, but how you act about what you do, for example. So language frames perception and action. Now, something like these ideas is at work in medicine. I'd like to start today by talking about plastic surgery. Whether you judge a nose to be in need of medical attention depends not just on the objective reality of the nose, but on social norms about noses. 0% of you in the survey that you did thought that having a large nose was a medical problem. But 7% of you thought it was a concern of doctors. And we all know that rhinoplasty, nose jobs, is a huge business in the United States. 500,000 people seek evaluation each year for their noses, and 250,000 have surgery. We have 14 million plastic surgery procedures each year and spend over $10 billion on plastic surgery each year to change people's bodies, for example, their noses. So this young woman wanted to have her nose adjusted, and this is what a typical nose job might look like. Or this boy was much happier about his ears. He had a procedure known as a setback otoplasty. Otos is ear in medical jargon. He had his ears used to be like Mickey Mouse ears. He was teased at school. He didn't like it, so he wants his ears set back, as shown in this image. And you can see in the bottom he's much happier with his ears. He's smiling broadly after the modification. So we construct ideas about what our bodies should be like. We see them in a particular way, and then we apply medical technologies as a result of those perceptions to change the bodies to conform with our socially constructed ideals about what the right body should be like. Today, however, we're going to be examining these ideas of social construction mostly through the lens of women's health and Emily Martin's remarkable book. And I should stress that this is not restricted to women's health issues, of course, though it's a particularly rich example. Now, this is the typical diagram of the menstrual cycle that you all learned in high school biology. The endometrial lining undergoes cyclical regeneration. Initially, it proliferates, so you have the estrogen peak here. These are the hormone levels of estrogen and progesterone. Estrogen peaks and spikes just before the corpus luteum cyst. So the corpus luteum is the development of the egg. Then the egg erupts from the corpus luteum. This mature egg is released. Then you get the progesterone spike. And here you have the endometrial growth. This is the lining of the uterus, which gets thicker and full of more blood vessels to prepare for the implantation of the egg. But then when no egg is implanted, you get the sudden drop of progesterone, and the withdrawal of the progesterone causes the menstrual lining to slough off and then be expelled through the vagina in the form of a menstrual period. So in time, as I said, the secretory lining provides a hospitable environment for one or more fertilized eggs. And as I said, if the egg isn't fertilized, it doesn't implant, there's some shedding which the lining breaks down and blood and the lining come out. Now here's one textbook description of the menstrual cycle, which is typical of the books that you all read in medical school, or in high school rather, or in sex ed, or whatever you took. And it said, the sudden lack of these two hormones, estrogen and progesterone, causes the blood vessels of the endometrium to become spastic, so that blood flow to the surface layers of the endometrium almost ceases. As a result, much of the endometrial tissue dies and sloughs into the uterine cavity. Then, small amounts of blood ooze through from the denuded endometrial wall, causing a blood loss of about 50 milliliters during the next few days. The sloughed endometrial tissue plus the blood and much serous exudate from the denuded uterine surface, altogether called the menstruum, is gradually expelled by intermittent contractions of the uterine muscle for about 3 to 5 days, and this process is called menstruation. Well, look at all the decay and failure here. Black and spastic and ceases and dies and sloughs and oozes and is denuded and lost and more sloughing and more denuding and more expulsion, right? I mean, this is like the wasteland that's occurred here in this description of this process. Full of all of these words that, you probably never called into question. And when I had read all these descriptions for my whole career, I thought, well, that's what you described. What's happening? The blood is oozing, and the cells are dying, and they're being expelled, and there's a loss, and that's totally normal. That's what's happening. It's objective reality. Now contrast this with the process of failed reproduction in men. The mechanisms which guide the remarkable cellular transformation from spermatid to mature sperm remain uncertain. Perhaps the most amazing characteristic of spermatogenesis is its sheer magnitude. The normal human male may manufacture several hundred million sperm per day. Wow! It's an unbelievable accomplishment that's occurring in these gonads compared to all the death and destruction that's occurring in the other gonads. There's no discussion here of the waste of sperm, or spillage, or sloughing, or resorption, or any other kind of decay whatsoever. This is just an unbelievable miracle on this slide. And contrast both of those with a similar, but not identical, physiologic process that occurs in both men and women. Okay, so you might say, well, men and women are different. Nicholas, how can you be sure, maybe this isn't gender, maybe it really is objective. Well, let's look now at another process that is in both women's and men's bodies. How is that handled? This is the renewal of the gastric epithelium. The primary function of the gastric secretions is to begin the digestion of proteins. Unfortunately, though, the wall of the stomach is itself constructed mainly of smooth muscle, which itself is mainly protein. Therefore, the surface of the stomach must be exceptionally well protected at all times against its own digestion. This function is performed mainly by mucus that is secreted in great abundance in all parts of the stomach. The entire surface of the stomach is covered by a layer of very small mucus cells, which themselves are composed almost entirely of mucus. This mucus prevents gastric secretions from ever touching the deeper layers of the stomach wall. So the point here is that the way we see menstruation in a particular way, or the point here is that we see menstruation in a particular way, and we describe it in a particular way, and that these two are related and they are not arbitrary. And as we shall see, such views of bodily processes in turn have implications for what we do. Now, Martin criticizes all this, but of course she does something else. So when I first was reading this book 30 years ago, I was like, yeah, Emily, what are you talking about? This is just objective, like the uterine cells are being sloughed. You're really being overly dramatic in your comparison of these two things. How else would you describe it? And what does she do on the next page? And I hope you did the reading. This is what she does. She provides a physiologically accurate but socially reconstructed way of describing the same phenomenon. This is Emily Martin's description of menstruation. A drop in the formerly high levels of progesterone and estrogen creates the appropriate environment for reducing the excess layers of endometrial tissue. Constriction of capillary blood vessels causes a lower level of oxygen and nutrients and paves the way for a vigorous production of menstrual fluids. As part of the renewal of the remaining endometrium, the capillaries begin to reopen, contributing some blood and serous fluid to the volume of endometrial material already beginning to flow. Production, flow, beauty, right? It's totally re-narrated description of the same exact process, and it's not scientifically inaccurate. And the point here, of course, is that conditions are judged by a social normative standard. Whether we see something as pathological can depend on who we are, where we stand, and when in time we are living. And you showed this yourselves in the exercise that you did for class today. So here are some initial ways that you guys constructed illness. So 0% of you thought that large nose was a disease. Actually, previous years, like 2% of you had thought having a large nose was a disease. 7% are concerned of doctors. 0% thought that homosexuality was a disease. Are you guys aware of the fact that like 30 years ago, homosexuality was seen as a disease, right? By the majority of people in our society, and even by official medical bodies. Homosexuality was seen as a disease. It was a concern of doctors. 7% of you thought it was a concern of doctors, but 0% thought it was a disease. Road rage, you didn't think it was a disease. Some of you thought you might want to get medical attention. PMS, 24% of you thought PMS was a disease. I'll come to you in just a moment. 66% thought it was a concern of doctors. Back pain, 23 and 88%. Acne, 17% thought it was a disease. Obesity, 61%, ADHD, 66%, alcoholism, and so forth. Even hay fever, 73%, and anorexia. I'm interested in the fact that you guys think, more of you think that hay fever is a disease than that acne or ADHD is, but anyway, that's where you are. 85% of you think that anorexia is a disease. So even though rhinoplasty is one of the most common nose jobs, one of the most common surgical procedures, you did not consider having nose to be a big problem. But obesity hit your radar screens more. And as we discussed a couple of weeks ago, some of these conditions, such as back pain and anorexia, show substantial cross-cultural variation, and actually may be seen as culture-bound syndromes, and might not be considered diseases elsewhere at all, and indeed might not even exist elsewhere at all. In cultures which don't think of back pain as a disease, maybe people don't have back pain. As if the absence of a category suppresses the occurrence of an illness and vice versa, just like the colors example that I opened the class with today. Labels, in fact, are sometimes applied by physicians and are the products of expert knowledge, and sometimes, of course, they're also sought by patients. So I'm not suggesting that this is something doctors do to patients. We together all participate in a culture that creates these categories, and then we live under those categories and experience the world as a result. But which definition of health is used can lead to contested labels. For example, in PMS and ADHD and hay fever, we see a tension between the social and statistical definitions of health. How can the majority of people be labeled ill? How can the majority of boys in elementary schools be diagnosed as having attention deficit disorder? It's a problem with the schools, not with the boys, right? We are saying, oh, we're going to define this type of behavior, fidgeting, and inattentiveness, and then we're going to medicate, we're going to prescribe Ritalin at huge level to these boys, which is absolutely not make sense. How can we say that 24% of PMS is a disease and 66%? Maybe it's just a normal part of life to have these experiences. And once we call it a condition, then the train leaves the station. We have to then start treating it, seeing a doctor for it, and so forth. Or is it the opposite? If I tell you that PMS is, as you might be thinking, and this is not what I'm saying, not real, then you might be saying, oh my goodness, it's punitive towards women, denying their experience. They're experiencing their bodies in this way. They're suffering with this pain. We should do something of it. You see, it goes both ways. It's not easy. It's difficult. But the point is, the conditions are socially constructed. They're not objective. They're not out there. In fact, you guys were all over the map in your perceptions about what constituted disease and what needed the attention of doctors. So childhood short stature, 10% of you thought it was a disease, 56% thought that short people were legitimately the concern of doctors. PMS is here again. Color blindness, 44% of you thought that color blindness was a disease. Interesting that you chose that definition. There's natural variation of whether people are colorblind or not. Pedophilia, 39% of you thought it was a disease, only 46% thought it was a concern of doctors. Cocaine overdose, obesity, full-on blindness, hip fracture, and alcoholism shown in this case here. Now let's take a closer look at one class of phenomenon that you guys responded to. These are various ingestions. So smoking 4 packs a day, 27% thought it was a disease, 95% a concern of doctors. Habitual cocaine use, alcoholism, lead poisoning, lung cancer, cocaine overdose, hangover. Very interesting that very few of you thought that this was a problem. I hope that's not specific to this class, but rather a generic feature of Yale undergraduates, and Tylenol overdose. Now, what might explain some of the variance and some of you made different decisions about these things? What explains some of the variance, you think? What are these categories differ? What are meaningful axes along which they differ? Yes, in the back. What's your name? Anna Isabel?
Yeah.
Uh-huh.
Maybe some of these things involve like a choice.
Yeah, the voluntariness of it might matter. So for example, you might think that lead poisoning, you didn't choose to poison yourself with lead, that's a disease and a concern of doctors, but cocaine overdose, you chose to take that cocaine, so that's not a disease and less of a concern of doctors or whatever. Okay? Voluntariness might affect whether you construct the thing, this ingestion, to be a disease. What else? What other axes? Yeah, Jules? No, what's your name? Yeah. Lila. Severity, yes, exactly. So hangover, but alcohol alcoholism, yes. Okay? So severity would also affect whether you construct the thing to be a disease. Something else, other ideas. Yes, what's your name?
Chase.
Chase, yeah.
Our perception of how common they are in society.
Commonality, very good. Excellent. What else? Yes, Charles? Stephen.
Fatality.
Fatality, yes, severity. Of course, you're going to take things like, I don't know, lung cancer much more seriously, or cocaine use than smoking, for example. All of these are other axes: severity, chronicity, voluntariness, frequency, that you use then to define whether or not this thing that's an objective reality is considered a disease and a concern of doctors. And this social construction also touches on the debate about medicalization we discussed a couple of weeks ago as well, and which we'll be returning to next week when we read Ivan Illich. It's interesting which problems you thought doctors should concern themselves with and which you thought should not. So for example, if you look at these categories, 7% of you, interesting, thought that global warming was a disease. Only 37% thought it was a concern of doctors. I guarantee you in the coming years, more and more people will think that climate change should be discussed in medical school, okay? And doctors should be trained about this. Nuclear war, around the same level. Sadness, you don't think that's a disease, but maybe doctors can help. Compulsive gambling. Only 7% of you thought poverty was a disease. 39% thought, only 39% of you thought it was a concern of doctors. And you go on down the list, but what amazes me is 76% of you thought that hemorrhoids were a disease, and 90% of you thought it was a concern of doctors, but compare that to poverty. I mean, hemorrhoids aren't killing anyone. Poverty is a leading killer in our society, but you think doctors should be paying attention to hemorrhoids. So why are you privileging hemorrhoids over, as a disease, let's say, over poverty? Is that an objective? I meant that rhetorically, but okay, yeah, right?
Yeah.
Yeah, why?
I was just gonna say maybe it has something to do with like what counts as being like a part of someone's body.
Yes. Very good. So maybe what if I told you, yes, very good. So something that's physically in your body. Yes, I forgot your name.
Jordan.
Jordan.
Hemorrhoids are more manageable and easier to
Yes.
make go away.
Yeah, very good. Exactly. So maybe doctors, one of the other axes by what they define as an illness is something I can fix. If I can fix it, well, that's a disease. If I can't, it's not. Yeah, right behind Jordan. What's your name?
Yeah.
Kayala?
Yes. I think that also has to do with what degree a doctor can be involved in someone's life.
So to what degree what?
A doctor can be involved in someone's life.
Can be involved.
Yeah, because if you were to address poverty, I think that would be more invasive than addressing infection.
Okay, so maybe, so it's very good. So in other words, it's like, for me to really address your poverty problem, I have to really get into your life, whereas with this other thing, I just give a prescription. Stephen.
Yeah, building off that point, it's kind of like how many steps away from it are you? So
Yes.
For example, with like alleviating certain symptoms that you may be feeling, like say with a hemorrhoid versus like combating poverty is.
Okay, so we're going to come to this issue that you mentioned in about 2 or 3 lectures, this idea of a causal chain. A causes B, causes C, causes D, causes E, causes the disease. And where along that path might doctors rightly intervene, and why we draw a distinction between different spots. So, the point again though is that, which things are considered to be diseases or legitimate concern of doctors are in fact quite arbitrary. Hence, the social construction of illness leads to medicalization. And this process involves seeing doctors for progressively less serious conditions. If we can arbitrarily define what is a disease, well then we can progressively change that boundary and lead to more and more of less serious things like acne. In the olden days, you didn't see a doctor for acne. Now we invented treatment for acne. Now you go see a doctor for acne. Seeing doctors for non-medical conditions, or the redefinition of such conditions to be under the purview of doctors, like road rage. 20% of you thought that people with road rage should go see a doctor. I might think, you just need to chill out a little bit and, drive better. Or seeing doctors for normal parts of life experience, like being fidgety in school if you're a boy, or having PMS, for example. And by some accounts, there's an epidemic of medicalization. There can be, in fact, a kind of social iatrogenesis. Iatrogenesis means doctor-caused injury. A kind of social iatrogenesis that we'll return to next week. And here's a list, in fact, of some conditions that have recently been medicalized. We understand all of these things increasingly in medical terms, whereas formerly we may have understood them as non-medical problems. So for example, PMS, ADHD symptoms, erectile dysfunction wasn't previously seen as a medical problem, now it is. Baldness, short stature, acne, infertility, child abuse was previously seen as a moral or legal problem. Now people are beginning to think of it as a medical problem. Substance use, road rage, gambling, poverty, gun violence, climate change, and on and on. And in fact, medicalization, as we discussed, is the progressive annexation of non-illness into illness. And as sociologist Renee Fox has put it, health and illness have come to symbolize many positively and negatively valued biological, physical, social, cultural, and metaphysical phenomena. And increasingly, health is coming to be seen as a coded way of referring to an ideal state of affairs. Now, incidentally, a demedicalization movement has also arisen, questioning whether objective categories can be deduced about health and disease, and questioning whether, in fact, illness is socially constructed after all, if illness is socially constructed, why it must be accepted. And recent examples include the contestations about autism, discussed in your readings, like why are we defining autism as a disease or a problem that requires medical attention? There's a neurodiversity movement that says, no, don't do that. We're just people with natural variation. We don't wish to be medicalized. Or, for example, and that was in your readings, or homosexuality, which in your generation has undergone a complete transformation in the last 20 years. And part of this movement has focused on disempowering doctors and empowering patients, giving them rights to treatment, rights to privacy, rights to information, rights to life, and even rights to death, which we'll return to next week. Indeed, more doctors, health organizations, and students are pushing for medical education to include climate change. For example, saying that physicians and other healthcare workers need to prepare for the risks of this. This was just like, this was a year ago. Medical schools are pushed to train doctors for climate change. Movement backed by the American Medical Association starts to grow, though content can be hard to fit into an already packed curriculum. And consider, for example, the epidemic rise in ADHD in the United States in the last 20 years. An estimated 11% of children in the United States have been diagnosed with ADHD. Between half and 2/3 of these children are put on medication. So this is time across here. This is the rate of office-based visits. These are boys with ADHD, which are just spiking. Boys that are put on a stimulant, and girls here. Do we really think that this biology of these young people is actually changing our society? Or do we instead think that we are socially constructing new illness categories and creating an industry that requires the treatment by the dispensing of medications or seeing a doctor? Is this epidemic real or not real? Is there an objective reality, or is it all subjective? The United States, in fact, is an outlier in the number of Ritalin prescriptions it gives to children. And the epidemic would appear to have struck us especially hard, which again comports with the idea that it's socially constructed. I mean, why are we especially being afflicted by this epidemic and not, let's say, other rich developed countries? And in fact, 66% of you guys thought that ADHD was a disease, and 85% of you thought it was a concern of doctors. You have wholly yourselves adopted this idea. Most of you think that ADHD is a disease. You've socially constructed it. Just like the menstrual period example I gave you a little while ago. And you think it's fine and appropriate to treat these kids with powerful medications. Well, something similar is also in fact happening with autism, and in all likelihood, where diagnosed cases are rising as disease categories are defined and contested. And as you saw in your readings, what counts as autism and who gets to say and what it means is contested and socially constructed. And the definitions depend in part on the ways of defining health that we saw a few lectures ago. So in the reading, he doesn't use the terms that I introduced, but he's debating how do we know, whether people are, what does it mean to be an autist? So the statistical standard compares people to their peers, and autists, unless they're high functioning, may be defined as disabled. The adaptive standard compares people to their environment, and so autists may have a disease or not, depending on the situation, and they're fit with whatever the environment is. For example, similar to sickle cell trait. Okay? If you have sickle cell trait and you're in South Africa, that's actually really terrific. But if you're not in South Africa where malaria is prevalent, it's not terrific. So whether you consider sickle cell trait to be a problem depends on the environment. Whether you consider autism to be a problem depends on the environment. Maybe you should fix the environment, is the argument. And the social standard compares people to normative ideas. And so autists may be seen as merely different, with different actors having different views and for different reasons. And this matters. It matters because seeing autists as simply normal variants would mean no extra services, but seeing them as sick might lead to stigmatization. So you get people on both sides of the debate. Some people say, no, we wish to have a label, because if we have a label, we get more resources. And other people say, no, we don't want the label, because if we have a label, we get stigmatized. On both sides, people with the condition and people without the condition. And Jarmsma and Whelan, in your readings, propose a model that uses the concept of vulnerability as a way out of this conundrum. Now let's return now to childbirth. I don't remember what percent of you thought pregnancy was a disease state. Some fraction of you did. And 96% of you thought it was a concern of doctors. And some fraction of you thought that birth itself was a disease state, or at least in previous years. I don't have the updated numbers here. I'll tell you, your colleagues, the last time, 8% of you thought that birth was a disease state, and 93% of you thought it was a concern of doctors. And as Martin argues, notions of production, like we saw with the menstrual example, run rife in this event, as in the other she considered. The pituitary is producing the hormones, follicular stimulating hormone and luteinizing hormone, FSH and LH. The ovary is producing estrogen and progesterone and eggs. The uterus is producing lining and babies, but not menses. And all the while, hormones, eggs, embryos, babies are transported from one place to another. The woman's body is like a veritable factory where stuff is moving from one place to another, all in the service of producing this baby. And as such, menstruation and menopause are seen as failures of production. And as a result, they elicit negative views. In fact, menstruation is not just seen as a failure to produce a baby, but as production gone awry, making products of no use, not to specification, wasted. It's not just a failure to produce a baby, it's doing the wrong thing. And in fact, labor during childbirth can also be seen as failing. A woman may be seen as failing to progress. Raise your hands if you've heard that expression to describe labor. This is a medical term. You say the woman is delivering a baby, and we say she's not making good progress. She's failing to progress as she's delivering this baby. And so as a result, she's seen as merely participating, the pregnant woman, in a production process that must be monitored and managed. So the way of seeing the body then has consequences. Women become disconnected from their bodies become fragmented, and doctors intervene. So here's a woman that's about to have a baby. Now she's been anesthetized. What do you notice in this picture? What's interesting about this picture? Any thoughts? Yeah, Caleb. Yeah, they're not looking at the woman producing the baby. They're all like looking over at the monitor. You know, she's just like a machine now in this type of situation. She's just become another machine producing a product, and here now is the baby about to be born. And in fact, as Martin points out, the delivery can be mapped as a production process. And this is a different diagram than the one in her book, although it's also taken from medical sources. The mere fact that there are such flow diagrams is itself interesting and suggestive. Even the pre-delivery phase has a flow diagram. So this is preparing for a pregnancy. That has to be part of the flow. And then conception. And then suspect that maybe I am pregnant. And then confirm the pregnancy. Now you have to manage the pregnancy. And here comes labor and delivery, which goes into this whole thing, labor and delivery. And so there's like planned vaginal birth. Can the woman have a vaginal birth? Let's see. Or must she have a C-section? Planned vaginal birth. If she has a spontaneous labor and routine progress, then she gets to have a vaginal birth. If not, what happens? She enters the flow chart, right? So my God, here she is. She's not progressing. She needs induced labor. Failure to progress, C-section. She has complications, C-section. Maybe she has a planned C-section, C-section. Maybe she wants a spontaneous labor, but then there are more complications. Oh, C-section. Failure to progress, let's try to fix it by giving her some medications. If it worked, okay, fine. But if not, it didn't work, C-section. Like everything is leading to this medical intervention, right? You create this type of a system, a flow chart. You imagine that it's like a production process. You map it out as if you're an engineer controlling widgets and knobs, and this then changes how you treat the person. And in fact, notice how seemingly tangential normal deliveries are. So many arrows lead to C-section with so many failures to progress. So our ideas about what delivery is like, our social construction of this biological experience has implications, leads us to take actions, like doing all the things in this chart, precisely because we define concepts of like normal labor and failure to progress. There may, in fact, be nothing objective about these landmarks at all. They may be socially constructed out of thin air with no evidentiary basis whatsoever. Here's some images from your readings regarding a woman undergoing a C-section. These are, I'm going to give you some tame images because I don't want to put them on not because I don't think you can handle it, but because I don't want to go there right now. But this is, what a typical cesarean section looks like. There's a drape. These are all the instruments that are used. There's a drape here. The woman's head is up there. Usually she's awake. And she's just anesthetized her below the waist. And the doctors are now preparing to make an incision in the body. They make an incision. They cut through the skin, then the fat layer, and then the muscle layer. They lift it up. Then there's the uterus. You need to cut through the uterine lining. And here's a baby now emerging via cesarean section from the woman's uterus. And then they have to suture up the uterine lining and the body as well. And in fact, many practices that have been widely adopted based on our conceptions of female labor have actually, when they've been now subjected to formal scientific study, to randomized controlled trials, have been shown to have little or no benefit. So all those little branches that I told you about, where the doctors invented all these tests and instruments and drugs to treat all these conditions, failure to progress, oh my God, the fetal heart rate is changing, you've got to do something. After those procedures were introduced and widely used, people went back to actually do randomized controlled trials. And most of them don't work, offer no benefits. So for example, electronic heart monitoring. An RCT was done in 1990. There were 93 people, showed no improvement in neurological development of prematurely born children. It didn't help. Induction of labor, RCT in 1992, 3,400 people, slight reduction in cesarean section rate, no effect on perinatal or natal morbidity. Active management of labor, no effect on the rate of cesarean sections. Monitoring fetal oxygen saturation levels during labor, huge trial, no benefit. No effect on the rate of cesarean sections, no effect on the condition of the newborn. So we do all of these things. We tether the woman, we put all these things, devices upon her, and then, in fact, it turns out we're not affecting the objective reality, even though we are responding to and affecting the subjective reality of the process of delivery. In fact, Dr. Emanuel Friedman's studies on normal and abnormal labor progression defined how labor should be managed since the mid-1950s until today. And although Friedman's studies were conducted among pregnant women in the United States, the general belief that labor progression is the same in humans led to universal application of his findings, and the expectation that the cervix of a woman should dilate by 1 centimeter per hour in all women during established labor. In fact, since the early 2000s, researchers have begun to find evidence that the patterns of labor progression described by Friedman actually may not be accurate. And this has generated a lot of controversy. So you guys know, like a woman goes into labor, her cervix begins, so the cervix is like a tight column like this, has a tight opening, and it's long. And then what happens is slowly the opening enlarges as the baby presses down on the cervix, and the cervix flattens, it faces. So it goes from being like this long, to being this long, to being less long, and it opens up like this until the baby's head can come through the cervix and exit the vaginal canal. So it used to be thought that the opening of the cervix, so is it 1 centimeter dilated, 2, 3, 4, 5, up to 10 centimeters dilated, that you added a centimeter per hour. But then people got around to measuring it. And what they find is that's really not the case. This was a prospective, multi-center cohort study of over 5,600 women in Nigeria, across 13 Nigeria and Uganda, who were giving vaginal birth, and they found that contrary to the generally held view, natural labor progressed much more slowly than previously reported. So for example, So this shows the cervical dilation. This shows the 95th percentile of cumulative duration of labor among women with the first baby that have never delivered a baby before. This is time since admission to the hospital. So if a woman's admitted to the hospital and she's 1 centimeter dilated, she might take 14 hours before she can get to 4 centimeters. And then she might take another, I don't know, however many hours, another 4 or 5 hours before she gets to 5 centimeters dilated. So it takes 5 hours to go here. And then it may take 2 hours to go here. And in fact, the labor may move much more slowly in the natural state than we thought. So we define normal labor as taking a certain space, and then we say, oh my God, there's failure to progress, and then we cut you open to deliver the baby. You see, our arbitrary construction of what normal labor is changes our actions. And that's one of the most important ideas I'd like to communicate today. Now, contrast what we have just seen of how we treat women's bodies, when we're talking about menstruation and delivery and so forth, with how we treat men's bodies. And Martin gives this example of reversing the gender. She says, if your husband was told that he had to get an erection and ejaculate within a certain time, or he'd be castrated to remove the sperm, do you think it would be easy? To make it easier, perhaps he could have an IV put into his arm, be kept in one position, have straps placed around his penis, and be told not to move. He could be checked every few minutes. The sheet could be lifted to see if any progress had been made. Like, we think this is ridiculous, right? Well, this is what we do when we define delivery in a certain way. This is exactly her description of what's happening. The doctor goes in, checks the woman to see if the baby's coming out, straps her down, and does all of these, don't move, and all of these other things. And as Martin notes on page 58, this strikes us as ridiculous, and yet she also documents women in labor are often kept in structurally analogous positions. Now, I don't mean to exaggerate, but stories like this catch my eye every year, since they're an almost logical extension of what we've been seeing. So this says, prisons often shackle pregnant infants in labor. You're going to see a story like this, I guarantee, in the next few months. Every single year there's stories like this in the news. Have you ever seen a woman in labor? You ever seen a woman in labor? Can you imagine a woman delivering a baby trying to escape? I mean, she's delivering a baby. This woman is not going to be able to escape. The idea that you would shackle a woman because she's a prisoner while she's living, this is absurd. It happens all the time. And I would argue it's a result in part of how we see labor, how we see women's bodies in this case. So Shawana Nelson, a prisoner in McPherson unit in Newport, had been in labor for more than 12 hours when she arrived at Newport Hospital. Her legs were shackled together. She's delivering a baby, and they shackled her legs together. And did nothing stronger than Tylenol. She begged, according to court papers, to have the shackles removed. Though her doctor and 2 nurses joined in the request, the guard in charge refused. What a son of a bitch. She was shackled all through labor, said Miss Nelson's lawyer. The doctor who was delivering the baby made them remove the shackles for the actual delivery at the very end. And despite sporadic complaints and occasional lawsuits, the practice of shackling prisoners in labor continues to be relatively common. State legislators and human rights groups say only 2 states, California and Illinois, prohibit the practice. That's a travesty. It's unbelievable. Now I'm a doctor, and so some of the stuff I've been showing you is fairly mundane, and I've tried to show you only tame and reasonably discrete images today. There are many more pictures in Martin's book, of course, and on the internet that can give you an idea of how mechanized and dehumanized the process can truly be. But before I leave this particular topic, I just want to go into one more example of the consequences of the way we socially construct childbirth. Episiotomy is a procedure. This is a picture of a woman in the lithotomy position. These are her legs. This is the anus. This is the vaginal canal. This is the head of the baby. And this is the hand of the doctor with a pair of scissors cutting this part of the body. And this is done to make it easier for the baby to come out without tearing the woman. So many women in natural childbirth tear, and they can have either a lateral tear away from the anal canal or a midline tear that goes down to the anal canal. Now, actually, those tears are serious. I'm not making light of the tears. Just because they happen naturally doesn't mean that they're good. And doctors originally, from a well-intentioned kind of desire, they said, well, maybe if we have a surgical cut instead of a tear, this will be a better state of affairs. But they didn't evaluate it. They just started doing it. So episiotomy rates skyrocketed in the United States. And it was previously believed that to prevent tearing of the vagina, as well as damage to the pelvic floor, you needed to do this. And this became a routine procedure in the United States for a century. Roughly half of American women have this done to them at delivery. Most of your mothers did. But in the past decade, studies have provided strong evidence that postpartum pain is less with spontaneous lacerations than with episiotomy. And studies have also shown that women return to sexual functioning earlier with intact perineums or spontaneous tears compared to women who had had episiotomies. The belief that episiotomy prevents damage to the pelvic floor has not been substantiated. And in fact, midline episiotomy significantly increases the risk of anal sphincter laceration, which then can make the women fecally incontinent. Now, I suggest that one of the reasons that episiotomy is so common is that our views of women's bodies as a machine producing a baby, a machine that needed some engineering and modification to make the baby come out on schedule. You know, we see the woman as a machine producing a baby. We need to flip some levers and twist some knobs, make some little adjustments, then the baby will come out as we define is the right way to happen. And further evidence, and on schedule, right? You have a labor progresses in this way, it has to come out on schedule. Further evidence of the social construction of the need for episiotomy comes from its telling variability. Women who deliver their babies attended by physicians in private practices undergo episiotomy 67% of the time, compared to women attended by hospital faculty physicians who are not paid for the procedure. And those women only have episiotomies 18% of the time. There's nothing objective about whether you need episiotomy. It's if you get paid for it, they do it. If you don't get paid for it, they don't do it. Talk about social construction. And in fact, there's enormous international variation, with some wealthy countries having an 8% rate and others a nearly 100% rate of episiotomies. And even in the developing world, for example, the countries sampled in the Boren study that was in your readings, a total of 25% of women got a tear. And alas, those with severe tears who had them surgically repaired, 14% were done without anesthesia. That's another thing that's just unbelievably appalling. It's especially a problem in the developing world, but it even happens in the United States. You have a woman, you have come to see her body in a certain way. It's very stressful on her, on the spouse, even on the medical staff, the delivery process. It can be very bloody and messy. A lot of stuff is going on. It's very high stress. But then afterwards, you're like, oh, I'll just suture her up. And you put sutures here without anesthetic. This happens all the time. And the woman is so distracted by other stuff, even though it hurts like hell, doesn't complain necessarily or doesn't say anything. And in fact, the abuse of women is not limited to modern Western settings. During the labor observations in this study, in your readings, 14% of the 2,000 women studied experienced physical abuse, most commonly being slapped, hit, or punched. So it's not just in our society that we shackle the women when they're in prison. This is, these countries I think were in, I forgot what they were. They were Myanmar, Nigeria, Ghana, and the fourth country, I forgot what they were in the Boren study. And what she found is that these women were being, 14% of these women were being slapped, hit, or punched. Like, stop screaming, you know, bang, slap the woman delivering a baby, for example. And 38% experienced verbal abuse. And physical and verbal abuse peaks 30 minutes before birth until 15 minutes after birth, and were most concentrated in the 15 minutes before birth, when she is at her most vulnerable, when this baby is coming out, when she's giving birth. And in Spanish, the expression is miraculous, dar a luz, bringing to the light. She's giving birth to this child. She's being physically and verbally abused. And you can see peeking right in this study, in this slide taken from your readings. Now, just as there has been a resurgent interest in natural death in the last 30 years, which we'll come back to next week, there's also been a resurgent interest in natural childbirth, in part as a reaction to everything that I've just shown you. And Martin discusses this at length in her book, and you'll also again find pictures in the book, which I won't show you here. But note the difference between this image and the one that we saw earlier? What are some differences between this image and the medicalized childbirth we saw earlier? Yeah, what's your name? I forgot.
Jalen.
Jacob.
Jalen.
What?
Jalen.
Jalen.
There's no machines.
Yeah, no machines. Very good. What else? I forgot your name again. Jordan. Jalen and Jordan. Okay. Also, your guys are helping me because you're not moving around too much, so it helps me when you're in the same seats to memorize your names. Yes.
Everyone's like focused on the woman.
Yeah, they're all looking at her. Who is this guy, do you think? If you had to guess.
Probably dad.
You think that's dad? Or is this dad? Who's dad? Oh, come on. This is dad. He has his hands on her leg, for the love of God. Okay? See the hand there? That's on the leg, on the knee? Okay, who's that, do you think? Probably brother, okay? And so here's the midwife delivering the baby. This woman's about to deliver the baby. Here's other people helping her. Everyone's focused on her. There are no machines. And there's something else that's very different about this picture. What's your name there? I'll call on you because you're way up there.
Hi.
Hi, what's your name?
My name's Liz.
Liz, yeah, what's different?
That she is upright.
Yes.
Laying on her back, which is really important.
Yes, she's sitting upright. And actually, the sitting upright thing is actually, you may have thought that the right way to deliver a baby is lying on your back. Why do women lie on their backs? Because it's easier for the doctor. So I can lay down on the table at this height. I can put the instruments in, can lift the sheet. I don't have to get down on my knees to do something, right? Because the baby's coming out from under her. But that woman standing up position, see this woman is down on her knees waiting for the baby, is actually incredibly old, right? We have art showing women delivering babies, that goes back millennia. And the women are not on their backs when they're doing that. They're standing upright because they have gravity working with them to pull the baby out. Now, conceptual models. I'm sorry, so are there any questions? Just pause there. I moved at a breakneck pace today because I actually had a lot of material to cover. But I'm going to take questions now, and then I'll have more material to give you. Any questions? Is anyone pissed off having said this? Upstairs, yeah, Liz.
So my mom was actually a nurse in labor and delivery, and she knew that this was a problem. So when I was born, you can request a birthing bar.
Yes.
Have them in the hospital, but most women don't know this.
Correct.
You have to request it beforehand, or else during labor they won't get it for you because there's so much going on. She
Yes.
did this. So she requested the birthing bar, and she was only in labor with me for about 15 minutes because she had these.
What birth order are you?
I'm the fourth child.
So an IQ deficit too? No, you benefited from that. No, so first of all, the reason she was only labor with you for 15 minutes, not just the birthday bar, you're the fourth child, so labor shows that. But yes, your point is well taken. I hope you didn't think I was picking on you.
No.
Okay, I'm teasing you. But anyway, but yes, exactly. And in fact, there are these birthing chairs where you can spread your legs and you sit up like on a little dais, so the doctor can be at eye level, but the woman is put into a vertical position. Now, conceptual models affect treatment, and there are many examples outside women's health, plastic surgery, and mental health. So today we've talked about women's health issues, plastic surgery, and mental health, but there are other examples. For example, stress ulcers. Even until I got to medical school, 30 years ago, people were thought to have stress ulcers because they were busy executives that were under stress. Does anyone know where ulcers actually come from? Bacteria, H. pylori. It's an infection. And we defined this way, and so the prescription was, you have an ulcer, you need to take it easy, you drink milk, actually that's the wrong thing to do. We had a totally different treatment of these things. Or something known as PVCs, or premature ventricular contractions, after heart attacks. When I was in residency, after you had a heart attack, if you had what was thought to be abnormal extra beats of your heart, of your ventricle, we thought, that must be bad. Let's stop it. And so there were drugs called flecainide and encainide that we used routinely. And then later studies showed were deadly. We were just trying to stop those extra beats because we decided that they were a problem and prescribed medications because of our perception of what was a problem. Or radical mastectomy, which we alluded to earlier, which was a procedure where if a woman had cancer, it sort of made logical sense. Like, let's just take out the whole breast and dissect up to the armpit and remove all the lymph nodes, and maybe we're going to damage some other stuff, and maybe the woman will have permanent swelling in this arm, or maybe the arm will be paralyzed because we damaged the nerve, but we're going to tolerate that. And then no one's thought until recently, like in my lifetime, well, why don't we try a different procedure? Why don't we just remove the tumor, do a lumpectomy, and give radiation? and preserve the breast, preserve the arm, and not necessarily harm women, our perception of the problem affects how we treat it. It affects how we intervene upon the person's body. So I need to be very clear about something, and I'm going to close with this point. It's very clear. It is not the case that modern medical care is not beneficial, and that all we need to do is to return to some natural time and place for childbirth. Here are some devastating WHO statistics. This shows maternal mortality by region in the year 2000. It hasn't changed much. So out of 100,000 live births, overall in the world, 400 women will die delivering a baby. But in some parts of the world, like sub-Saharan Africa, 1 out of 100 women, 1,000 out of 100,000, so 1 out of 100 women during delivery die when they're delivering a child. There's nothing in the 3 sample countries in your reading, in the Boren reading, and in the particular example of these women were in facilities, 5 out of 2,000 women, or 250 out of 100,000, died in that study, as did 2.3% of their babies. Just think about that. It's as if 2 of you suddenly died. That's the ratio of deaths that's occurring in this situation. The WHO Safe Motherhood Initiative regarding the provision of basic health care in this domain unfortunately did not have the success it should have. A certain small percentage of women with serious need serious advanced medical care on short notice. And in fact, maternal mortality in Africa is shockingly high and remains shockingly high. So my point is that efforts were made to improve worldwide the experience of women and babies during delivery, but it's actually quite difficult. You can't just do that with like a few blankets and some light training. Sometimes you need modern medical care to save the life of the woman and the baby. So the challenge is to separate what is social construction from what is scientifically beneficial. In a way, the challenge of being a doctor is to know when to respond to the statistical, when to the normative, and when to the adaptive standard of health. And my point is not to somehow simplify things in a silly way and say that the fact that these things are socially constructed means that there's no such thing as science or medicine, and to put these concepts of social construction and science and medicine into false opposition with each other. That's not the lesson I want you to take home today. And here, in fact, are some of the leading causes of maternal death worldwide. Women die delivering babies, and we can stop it using modern medicine. Just have to be smart about it. So 24% die from severe bleeding, 15% from infection, 13% from unsafe abortion. This is eclampsia, that's like a syndrome of high blood pressure and problems with your platelets and other issues and seizures in women, eclampsia. 8% obstructive labor. This is devastating. I didn't put this in my book Blueprint, although maybe I did, I can't remember. But there are women buried with their babies who died in childbirth, and you see the baby's body like in the woman's pelvis because she died during childbirth. They're buried together. Very moving. Other indirect causes, other direct causes, and other indirect causes listed. And these kinds of problems don't respond to midwives with kits, nor should we define them as non-problems because they are somehow natural. They can indeed be prevented with low-cost interventions, for example, reducing infection or unsafe abortions, though they are not easy to eliminate. And what's challenging about what I'm telling you is that these things are actually complex. The Martin critique is one of the best that I have seen, and is spot on in my opinion. But I want to challenge you even more, because there's also the reality of maternal and fetal death. And what we want is the best of both worlds. And it should be possible to have it. And in fact, this is what's so hard about being a doctor. You are really trying to integrate what's scientifically sound with what is human. And you don't always know what's right. And information is conditional, and it's tentative, and it's culturally constructed, and it's changing all the time. Okay. Any questions before I let you go? Yes, what's your name? Jules, yeah. Jules, Jordan, and you're Layla.
Lyle.
Lila.
So my that when Western doctors want to go and teach, doctors use the medicalized ways of handling those births, that it's actually caused an increase in mortality because doctors in those countries don't always have access to the medical devices.
Yes.
Right, that Western doctors have
Yes.
access to, and so then they begin to lose their ovaries.
Yes. So we might make things worse. That's exactly right. We might not have the same sterility practices or the right kind of clamps or the right kind of ways of coping with breech birth. That's right. That's another problem we didn't discuss today, although we'll return to versions of this idea later in the class. Yes, that's right. Any other comments? Okay, read the Illich for next week. It'll blow your mind. It's very similar to the Emily Martin, and we'll continue.